Great, thank you. And thank you for inviting me to speak. Okay, so we're going to focus on pediatric stroke. I have no real disclosure, but we have some contracts pending with GE and Canon. So pediatric stroke is predominantly made up of arterial ischemic stroke. Over almost 3/4 is arterial ischemic in nature as compared to venous sinus thrombosis and other types. And this is new data that's come out from a multinational consortium of over 3,000 subjects now. And this information was actually given to me by Michael Rifkin at our institution, who's one of the members of this consortium. So these numbers now are starting to get high enough that the proportions are probably pretty accurate. And if you go into the arterial ischemic stroke part of the pie, which is almost a 75%, within that, things break down as follows, with perinatal being almost a third of all arterial ischemic strokes in children. And you see that there's different age ranges over the rest of the year, from that first month onto the year, 12%, 1 to 5 years, 20%, 6 to 10, 15, 14, and then 9%. So you can see disproportionately represented is that perinatal population. I'm just going to take a side point here in terms of the etiology of arterial ischemic stroke in general for kids is much different and much more diverse than was most common in the adult populations. So there's quite a spectrum of disorders that can give rise to arterial ischemic stroke and different mechanisms than what is typical in the adult groups. And in particular, what's becoming more recognized, but I'm not going to spend time on today, is the arteriopathy, particularly with infection, inflammatory processes that can give rise to stroke. That's becoming increasingly recognized in the pediatric population. Now, coming back again to the distribution of ages, again, as I mentioned, the perinatal is the most common in the pediatric age group. So we're going to focus for this talk on perinatal ischemic stroke. Now, what the definition is for perinatal arterial ischemic stroke is a focal arterial ischemic injury, so that's within a vascular territory, between 28 weeks gestational age to 28 days of life. So this goes down into the fetal age group in the classification of perinatal arterial ischemic stroke. Just to be clear on what it's not venous ischemia, which tends to be subcortical and can extend to the cortical regions. It's not venous edema, and it's not venous hemorrhage. Each of those are venous types of, sometimes called stroke, because venous stroke can be termed or described in many ways. So each of these could be described as a type of venous stroke, but we're not talking about venous injuries. And we're not talking about other neonatal mechanisms such as partial hypoxic ischemic injury. Some people refer to these as watershed infarcts. I disagree with that point of view, and basically because when I look at the patients we see, for example, in this patient here, many of the lesions are within the major vascular territories. Same with this here. This extends actually into mostly MCA territory, and here we have MCA involvement. So to me, these are more than just watershed ischemic strokes, but they probably do rise from arterial side, lack of blood flow and oxygen combined with other factors such as inflammation. But we're not talking about this today. What I'm going to focus on is these arterial ischemic strokes that are due to focal vascular occlusion or temporary occlusion leading rise to vascular distribution ischemic strokes. Now, if we focus on just the ones that we detect in the neonatal time period, the incidence is somewhere between 1 in 2,300 to 1 in 5,000 term infants. So the incidence is actually increasing as we start to use MRI more often in this patient population because they're very hard to detect by ultrasound, especially if they're subtle. As I mentioned earlier, it's very common, and in fact, it's 17 times more common than pediatric arterial ischemic stroke greater than 28 days. So this is a period of high incidence of stroke in the pediatric population. Interestingly, the clinical symptoms can be very broad and not necessarily focal. The focal symptoms only are present in about a third. So more global findings such as apnea, hypotonia, seizures, systemic illness, resuscitation histories are present in these children. So they don't all present, and in fact, many do not present with any focal signs or symptoms. The diagnosis is based solely on imaging, so we are the one that helps to define in these vague symptom category which ones fall into the criteria for vascular arterial ischemic stroke. Up to a third may present later in life with developmental delay or asymmetric hand use or seizures. We're still missing some in the neonatal time period. Usually you can tell by the characteristics of the lesion and the patient history when they present a little later. So the evaluation that we perform at our institution, again, this is courtesy of Michael Rifkin, is for the baby. We run a blood and lab works to look for either transient coagulopathy or presence of abnormalities that suggest a genetic cause. We screen the urine, echocardiography to look for congenital heart disease, and placental pathology to look for potential etiology there. The parents are also screened for some of the most common inherited disorders of coagulation. And the goal is basically to see if we can come up with an etiology. In particular, is there evidence for infection? Is there evidence for transient or acquired coagulopathy or inherited coagulopathy? Is there congenital heart disease, a patent ductus arteriosus, a patent foraminovalle, placental clots or placental infection, or is there evidence of toxins? But bottom line is up to 50% we never find a cause. And the reason for that is probably that neonatal arterial ischemic stroke is quite unique. Pregnancy is normally a state of procoagulant, pro-inflammatory state, so it's not a typical state by any means. And the risk of stroke increases 34 times in the 3 days prior to birth. And that's because the coagulation mechanisms ramp up in anticipation of hemorrhage. So the adaptions that actually decrease the risk of bleeding during delivery increase the risk of clotting. And as a result, neonates most often have abnormalities in coagulation that may be transient versus abnormalities in fibrinogen activation, which is more typical for adult arterial ischemic stroke. And so therefore, in the neonatal situation, the causes are likely multifactorial, involving both maternal factors because of the pregnancy, placental factors, mechanistic factors during the delivery, and early postnatal adaptation where they're dehydrated, for example, as well as other environmental factors. So there's many causes that contribute, and that probably gives rise to the fact that we don't determine the etiology in the majority of them, and therefore it's very hard to come up with schemes to prevent. But on the good side, as a result probably of this alignment of multiple factors that are transient in some cases, reoccurrence is rare. So the vast majority of neonatal strokes do not reoccur outside of the neonatal time period. So this is our imaging protocol. We're fortunate enough to have a 3T with a 32-channel coil that allows us to do image acceleration. Frankly, because most of these are term, we don't take the time to bring them down in the MR isolette. And the coil that comes with the isolette isn't as good as our 32-channel. So I think there's only 8 channels on the isolette coil, so I can't do the same kind of acceleration factors. We run volumetric T1s so we can reformat, T2s that are pretty thin. And this is because of the acceleration, this is now 5 minutes. SWIs, DTI with 30 directions with 1,000 B value. And we're also starting to run PCASL routinely with variable delays depending on what we're expecting. And I'll show you some data towards the end on the PCASL. Other options are MRA of the head and neck. If the images look poor, then I go to Doppler ultrasound because it's one, at this age, you can get a good window through the squamosal suture to integrate the circle of Willis. And the neck carotid vessels are evaluated well with Doppler too. So if we run out of time or if there's artifact, we go to Doppler at the bedside. MRV we often run, but again, if there's areas we're concerned about, you can do a second interrogation with Doppler, or if you see a clot, you can follow at the bedside with Doppler ultrasound. We're just moving to more routine MR spectroscopy to see if that helps predict outcomes. Again, only because we've got now an accelerated protocol that's a volumetric acquisition that's about 2.5 minutes at 30 milliseconds. If you look at the vascular distribution over large numbers, again, it's starting to hold up or continue to hold up the left hemisphere predominance. And you'll see that in the examples that I show you. Almost all of them are left-sided. Again, probably because of the hemodynamics and probably because the origin of the clots is outside of the intracranial vascular system. One thing to be aware of in this day of age of multi-channel coils and also susceptibility boundaries at the petrous bones, for example. Sometimes it's hard in the DWI images to know which of these areas of bright DWI signal is a real ischemic stroke. If you process the data and go to the exponential images, you get rid of those shiny edges from the susceptibility artifact and start to better identify or confirm the areas that you suspect are ischemic strokes. And here in the ADC map, again, you can see that this is the only lesion that holds true as we look at the processed image. And the reason that is when you process the image, you divide by the T2 essentially, so you divide out those shiny bright edges. This child also had multiple other lesions that were embolic in nature. And unlike in the adult population, when you see this multivascular territory strokes, you usually think of cardiac etiology, atrial fibrillation, that type of thing. However, in neonates, it's more common as systemic etiology. So don't think about cardiac, think systemic. Resuscitation is highly correlated, maternal hypertension, and acute systemic illness. In this particular patient, the child had DIC, a GI bleed, a patent ductus, presumed sepsis, but no definite etiology was identified, and on echo, the cardiac system was normal. Beware of multiple findings. This is a child, then you're reading through the scans, and most of you, I think, will pick up pretty quickly. There's the arterial ischemic stroke in the caudate head, probably an embolic event because of the small size and deep location. Don't stop there, and also don't just look at the arteries. In the neonates, they can have clots in both the arterial and the venous system. So, for example, if you look at this child here in the sagittal, you can see that there's abnormal T1 signal in the sagittal sinus. On the T2 weighted sequence, it's a bit enlarged, and on the gradient echo, you can see blooming. So this is a case of a child with both arterial ischemic stroke and venous thrombosis. Turned out the mother had a factor V Leiden disorder, and actually that's what sent me double-checking the venous system because it's more typical for venous thrombosis. It's not clear where the arterial stroke came from because you can get arterial side strokes or arterial side thrombus or venous thrombus with factor V. Venous is more common, so this could have also come through a patent foramen or valley as well. So look in both the arterial and venous systems when you're dealing with neonatal patients. In this particular case, anticoagulation was recommended with low molecular weight heparin. In general, however, treatment is controversial. It's much more common in cases like I showed you, whether it's a thrombophilia or a history of cardiac disease. However, in many other cases, we don't thrombolyse, and I'll show you some reasons why. When we do thrombolyse, anticoagulation, again, is the most common. Again, that's because, as I mentioned earlier, coagulopathies are much more common than platelet abnormalities. So typically, we do start with low molecular weight heparin if therapy is considered. Also be aware of evolution. These are maybe complicated cases. First hint here, this is a premature infant at 32 weeks presenting with acute left-sided arterial ischemic stroke in essentially the entire MCA territory. You've got to wonder why this child is 32 weeks. There may be something going on. Comes back 15 days later after bedside ultrasound shows interventricular hemorrhage, and we see evolution of the thrombus or the stroke on the left. Again, note that we still have bright DWI 15 days later, so the time course of evolution is different than arterial ischemic stroke, with the low ADCs and bright DWI typically persisting longer. And in addition, we see bright DWI signal, low ADC in the subcortical white matter, prominent deep venous system, and interventricular hemorrhage. Look at that superior sagittal sinus, again, greatly distended. And this is an example of, again, what started out as first an arterial side stroke and then progressed to complete venous sinus thrombosis. And again, because the deep veins drain into the deep venous system, there's backup pressure, hemorrhage into the interventricular system, backup pressure into the deep medullary veins, giving rise to some hemorrhage and venous ischemia in the deep venous distribution. So monitor closely, especially in those that you suspect an underlying coagulopathy. This one ended up with an antithrombin 3 deficiency. Outcome was quite poor in this child because of not only the arterial vascular territory stroke, but because of the diffuse injury to the contralateral hemisphere. So this child was severely developmentally delayed. However, in general, in the simple arterial ischemic strokes, there is low morbidity, and prognosis is better than in the adults, probably because there's a little more plasticity and ability to adapt in the neonates. Boys are typically worse than girls in terms of outcomes. Over a third will have hemiplegia, but more importantly, again, what we're recognizing more and more in neonatal injury is you follow these kids, and almost 2/3 or over 2/3 will develop some kind of disorders such as seizures, cognitive delays, behavioral delay, or language impairment. So injuries early in life are increasingly being recognized as playing a role in later cognitive development. MRI and outcome, the most recent study on this, it had 80 patients, showed that if you see a mixed injury involving the cortex and deep corticospinal tract, you're more likely to have an abnormal outcome. Here they talked about hemiplegia. However, in this paper, they didn't really define what an abnormality consisted of. So there's low ADC in the corticospinal tract here that could be Wallerian degeneration or other findings. It wasn't clear in this paper. It's just saying if you identified abnormalities in both those situations, that outcome was that there's a high predictability of poor motor outcome. Now, how can we get better? Can we use ASL and DTI to better optimize treatment and better predict outcome? This is one of my favorite slides. It's now about 7 years old, I think. We've been playing around with ASL for quite a while. It's a great case, so because if you look right here, we've got this area of a ischemic arterial stroke, very low ADC, no blood flow. So this is what you'd expect in a typical adult situation. You got pan-necrosis. This is going to go on to cystic encephalomalacia. But we have many other territories with varying abnormalities, such as this area here that has some patchy low ADC but very high blood flow, and the contralateral side where there's no ADC or DWI findings, but we see hyperperfusion. And this probably gives us a hint to later outcome. And here's some with their outcome follow-ups matched. Low ADC, relatively preserved elevated FA, very high blood flow, going on to mild volume loss with just a little bit of encephalomalacia. Does the high FA help us predict that tissue will do well? Well, there is a limit. Here's an example here with low ADC. This part is starting to become higher. FA is extremely high. And if I take a look at that FA region and run tractography on it, you can see that it's not anatomical at all. It's lost any kind of normal anatomical structure. So sometimes in very high FAs, that's actually part of the signature of evolving necrosis. So preserved or slightly high FA is good, but very high FAs are bad. Here's an example here where there's a left MCA stroke. You can see the low ADC, bright DWI. You look on the SWIs, you can see that there's less veins visible here because of a higher oxygen content, presumably because of higher blood flow. The ASL was degraded by motion, but we do get a suggestion on here too that the blood flow is higher in that left hemisphere. And then on follow-up, we just had some mild volume loss with a little bit of gliosis, and we'll have to follow over time because the child isn't completely myelinated, but not cystic encephalomalacia. Whereas this child here with bright DWI, slightly milder decrease here, lack of blood flow in this posterior region goes on to cystic encephalomalacia where there's no blood flow, but areas where there's slightly bright DWI and preserved flow, minimal changes. This case is great because of multiple different abnormalities that we see. You see this area here, markedly swollen on T2, very low ADC, at this point preserved FA, but no blood flow at all, as opposed to, say, the occipital lobe, where there's only minimal changes on T2, ADC slightly less decreased, FA relatively preserved, but high blood flow. And then on follow-up, cystic encephalomalacia in the area where there's no blood flow, and some volume loss here where the blood flow has returned, but not as severe as over in the other region. So I think as we move on and start to characterize and then look at trajectories, we'll get better at this. General ballpark is lower ADCs are worse. Normal to slightly elevated FA suggests that the tissue is not doing badly at that time, and normal to increased ASL is better than no blood flow in terms of outcome. There's just another example, again, of the typical left MCA stroke. If you look on the MRA, it's actually the side of the stroke that you see the vessel versus the contralateral. And again, if you look on the susceptibility weighting, you lose a deoxyhemoglobin within the venous system. Here's the ASL at 5.5 second delay. then at a second delay and 1.5-second delays. This child was premature, so baseline blood flow and blood cerebral metabolism probably lower than term, so we had to pull out the delays in the arrival time, and you can see that there definitely is a faster arrival and higher oxygen or perfusion to the side of the ischemic stroke. And again, this is what I see most often, which is why a lot of these don't require treatment, is by the time we see most of these isolated arterial ischemic stroke, they're typically hyperperfused. When we go to the bedside with our near-infrared spectroscopy techniques, the other thing we see, as well as increased blood flow indices, is increased oxygen metabolism as compared to the contralateral hemisphere, suggesting that there's increased neural activity in these areas of ischemic stroke that might be driving up the blood flow. So it's not clear that this increase in blood flow is loss of autoregulation. It's more likely, in my opinion, to be increased end organ demand. So the injury mechanisms are leading to excitotoxic cascades, increasing the excitotoxic mediators that drives up neural activity and results in the demand for higher blood flow. So if seizures are playing a role, should they be cooled? That's one of the reasons why we cool kids, is when the neuronal metabolism is high and blood flow is high, we cool them to try to bring that down. And that is being discussed in a lot of ICUs right now, is should we start to cool some of these? And what is the role, I question, of some of these bedside methods? Because if we can get to the bedside and look at what the metabolism is of that particular child's brain, and we can identify kids with elevated oxygen consumption, are those the kids that would do better with cooling? Also, I think in the future, as we move forward, tractography and connectivity measures will also help us better determine what tissue is rescuable and how these connectivity changes are occurring with recovery from tissue. Just a cute example, looking at the interplay between maybe seizures and injury mechanisms. Nice arterial ischemic stroke with slightly increased FA, very high blood flow. If I put an ROI in that stroke, and I can track all these tracks from that ROI, and actually I'll just turn it on its head. So you can see all those tracks actually exist in that region of low ADC. So there still is some coherent tissue structure. If I put in the thalamus and only look at the common tracks, I can see that some of these tracks are actually cortical thalamic tracks. And there's the ADC map on that same child showing that there is abnormal tracks going right down to that thalamus, so cortical thalamic tracts. And we see this not infrequently, that we see thalamic changes in association with these often left hemispheric stroke, as you can see from my collection here. Some of them here, we see it in the VL thalamus and lateral lentiform. So it's not always direct ischemic injury. It's more likely in the vast majority network involvement, either due to metabolic stress from seizures like we see in status epilepticus, or perhaps from Müllerian degeneration. I think we still have to sort those out. And it doesn't just happen in the thalamus. We can also see it up here in the caudate if there's enough frontal regions involved. A quick point about DSC versus ASL. Why am I not sure doing any ASL images? I did actually crawl into the scanner when we didn't even have the tubing for it and injected kids bolus, because I was at MGH when everybody's doing perfusion imaging. That was back in the late 1990s, and I never found anything, and I think a lot of people had the similar experience. I think the problem with DSC in neonates is they have a very large venous blood volume. So your DSC images look like that if you look at cerebral blood flow. And basically all I see are the veins in the sulci. And here's a child of 18 months with a DSC injection, and this is the relative CBF. Again, all I see are the veins in the subarachnoid region, and I get a very poor assessment of cortical perfusion, as compared to ASL, where I can actually pick up the parenchymal signal and pick up cortical perfusion. So to me, the T2 star DSC is more a venous blood flow, so it's more venous blood flow, and arterial spin labeling is really a capillary inflow labeling, so we get capillary perfusion, which I think is much better at looking at hyperperfusion, which is typical in neonates as well. And then the same infant with ASL versus DSC. Again, much better resolution of the cortex and the deep gray structures, because we're seeing that capillary inflow instead of that venous blood volume. So I think as we move forward that it'll play more of an important role. It's about 5 minutes right now. You don't have to put an IV in, so you can repeat it. So it just needs a little optimization. There's always a differential diagnosis, so since it's kind of a clinical angle to this talk, I just want to mention that we have to be careful that we don't mistake herpes simplex virus infections for strokes. They can present with low ADC as well and can mimic many types of perinatal ischemic injury. Again, the partial hypoxic ischemic injuries are not the same thing. They're not multi-embolic. They have very vague margins, unlike the arterial ischemic strokes that tend to have very sharp margins. Hypoglycemia, think of that if the injuries is mostly posterior distribution and bilateral symmetric. And then there are some metabolic disorders such as citrullinemia that can present with cortical abnormalities as well. But these, again, typically don't present with an arterial vascular distribution. So some of the take-home points is pediatric stroke is a different etiology than adults. Perinatal stroke is common. Presentation is often nonspecific and nonfocal. Diagnosis relies on us. It relies on the imaging. Treatment is controversial, and given my experience with ASL, I'm glad we don't anticoagulate a lot because many of them are hyperperfused. And I think cooling is going to start to play a role in some of these children to prevent the secondary changes and optimize outcomes. And again, outcome is currently group statistics. We do very little in terms of predicting for individuals. But again, I think our armamentarium of new techniques will start to play a bigger role in not only improving our group statistics, but individual diagnosis. Thank you.